Good evening, sir.
Okay, we are live. So I'll request Chinmay sir, the President of West Bengal Orthopaedic Association, to give the welcome note.
Good evening, everybody. Can you hear me?
Yes, sir. You are audible, sir.
Hello.
Yes, sir.
Yes, sir. You are audible.
Okay. Okay. So, first of all, I welcome Dr. Ram Prabhoo to be here with us for this interesting webinar. So, and other faculties from our state also, I welcome and thank them to be here. So, after academic discussion of the subjects completed, discussion, question answer, and I request Dr. Ram Prabhoo to conclude the session at the end with the description and discuss on the pharma molecules. So with these words, I request the program to be started. Thank you.
Yeah. So good evening, everyone. On behalf of West Bengal Orthopaedic Association, also from JB Chemicals, thank the team of JB Chemicals who have got this webinar and all of us together. It's going to be an interactive session, and I would welcome the questions at the end of my talk. All of us are really going through a real bad time now of COVID, and all of us are also suffering, helping the patients, and also helping ourselves with whatever restriction of work that we have. Now, I would like to share my screen.
Arnav, do the screen share.
Yes, it's allowed.
One moment.
Yes.
Multiple. Yes.
So now,
now you can, sir.
Is the screen seen?
No, sir.
Not yet, sir.
One moment. There is slight some technical problem.
First open the presentation, sir. Then share.
Beg your pardon?
Sir, please first open the presentation, then share.
Oh, okay. One moment. There is little problem. I will get it.
Yes, sir.
Sir, just minimize the Zoom video, open your PPT, then again expand your Zoom video, then share your screen, sir. Then it will come.
Hello. त्याला विचारणार साईड स्क्रीन करता येत नाही शेअर तर नाही अरे मला परत शेअर स्क्रीनचा प्रॉब्लेम व्हायला लागला शालाय बरं मग नाही मी ना श्रेयाला बोलव नाही हा But keep it. No, I cannot do that. I have to give a talk just now. No, let it be like that. But the change kar lose झाला असेल तर अजून टाइट कर. 3 more weeks. I've opened it, but not getting out. One moment.
So you can do one thing. You mail your presentation to me. By the time I think we'll start with Kiran the lecture, and we will run it from this side, sir. I think there is some issue with Ram Prabhoo, sir. I think
Okay, so
we can start with the talk of yes.
Yes, sir.
Yes.
Yes, sir. Go ahead.
Yes, sir, we can see your screen now.
Is it seen now?
Yes, sir.
Can you see the screen?
Yes, sir. Please play it, sir,
Yes,
or
sir.
make it PowerPoint presentation mode.
Beg your pardon?
Sir, presentation mode, please make it in presentation mode or PowerPoint.
One moment, one moment.
Yes.
Yes. Yeah.
Slideshow from
We
start.
can see that. Just go in full screen mode, slideshow mode.
Yeah, I will do that.
From start. Yes, sir.
Can you?
Yes, sir. Now it's you are audible. You're visible also.
Okay, fine. I'm very sorry.
Yes.
Okay, so good evening, friends, and good evening, all the participants who have come to this West Bengal Orthopedic Association's webinar. We are going through real bad times with COVID-19, and last 4 months we are really struggling, helping the patients and also helping ourselves. The first thing is to take care of our own health along with the patients here, and that is a real risky thing that we are all going through. And I'm going to talk about the new normal or altered normal that we are going through in the orthopedic practice. So now the new terminology which has been used after this COVID-19 episode or a pandemic is COVIDology, which deals with the whole problems of COVID-19 and how to deal with it. And there are lots of theories, lots of different policies which have come across over a period of time. So I would just go through a brief history, brief things about this coronavirus, and which will help you to understand what is this coronavirus. The coronavirus is a single-stranded RNA virus of group 4 of virus classification, who gives its name as COVID-19. And COVID-19 is a new strain of coronavirus first identified in Wuhan city, China in December 2019. And that is how the whole pandemic has started, and it was coined as a pandemic in January by WHO. The incubation period of COVID-19 is 2 to 14 days. And that means that if a person remains well 14 days after contact with someone with a confirmed coronavirus, they have not been infected. And this is very important to understand, because during that time, he may be asymptomatic or symptomatic. And that is what has to be found out. And this is what the basic coronavirus structure is. We will not go into the details, but it has RNA or N protein, it has an envelope, M protein, E protein, and all that for a virologist to talk about. But this is the structure of coronavirus. Again, what are the signs and symptoms of COVID-19, and which are very, very important, because this could start as 1 or 2 symptoms, which could be very innocuous, which could be seen in everyday life, but we have to be aware of that, and we have to start taking the precautions for that. And basically they are dry cough or sore throat. Many times this starts as a dry cough and sore throat, and very many patients have loss of smell and loss of taste. And these are also very pathognomonic of this disease or this problem. Some of them really feel fatigued or tired, or sometimes muscular pain. Fever is many times seen, or most of the patients have fever in varying degree of temperature, which could be very high, as much as 103, could be 100 also. And diarrhea, which is incessant diarrhea, which is sometimes uncontrollable, is also a sign. Some of the patients start having breathing difficulty, and that could really worsen. Patients then have breathlessness, which can be really uncontrolled in many patients. So these are the simple coronavirus symptoms that we see. Some of them have a muscular pain, backaches, also backaches and neck aches, which patients come to us, orthopedic surgeons especially, and we have to be aware of these symptoms and signs. There are vulnerable patients who could be actually having these COVID symptoms, and these are basically elderly patients, those who are having weakened immune system, those who have comorbid problems like diabetes and cardiovascular disease, some cancer survivors, also chronic lung disease like COPD and other chronic diseases of renal or liver disease. So all these patients are vulnerable and we have to be taking care, especially in these patients. The COVID-19 death rate, if you see this, is in mainly above 50 years, and we'll see that almost 30% of the patients are above 50. But that doesn't mean that younger patients below 40 are not affected. But we have quite a few, almost about 1 to 2% death rate, which is seen in younger age groups too. And we have to be careful about it. So this is what is the death rate, and we have to be aware that this can be problem. So we have the spread of COVID-19, and these are very, very important, which we have to be taking care of, especially air droplets, touch, and closed groups. So this is one thing that is very, very common in spread of the COVID-19, and we have to be very careful about this. That's the reason why we have to wear all those precautions, etc. So how is the chain of transmission? And this chain of transmission is universally in all the infections that we see. There is a port of entry in the susceptible host, the infectious agents and reservoir, port of exit, mode of transmission. This is how the chain of infection is. And for infection to spread, all links have to be connected, and breaking any one link will stop disease transmission. And this is what we have to remember. And with the infection control goals in outbreak preparedness are to reduce transmission of healthcare associated infections, to enhance the safety of staff, patients, and visitors, and to enhance the ability of organization or health facility to respond to an outbreak. To lower or reduce the risk of hospital healthcare facility itself, amplifying the outbreak is very, very important. And for that, to prevent the spread, these three things are extremely important: the mask and the face shield, hand washing and sanitization, and social distancing. I will be talking about it in more details about the mask, the hand washing, the sanitization, and social distancing. And these are absolutely mandatory for everybody to follow this, whether it's a hospital staff, a menial worker, nurses, the healthcare providers, and the doctors and the surgeons themselves. So these are basic things, because OT protocol is totally different. Of course, we'll be taking lots of precautions in that, but these are absolutely mandatory. And the spread which has happened, or probably resurgence in Mumbai, Delhi, and Chennai, has been because of some kind of negligence, some kind of overconfidence which has occurred in these small, simple preventive steps. So, what are the standard precautions that one should take? First and most important is the hand hygiene that I talked about, the respiratory hygiene or cough etiquette, that you have to cough in your elbows and not in the hand, because these hands are susceptible to touch anything else. There are different types of PPEs, and according to the risk those PPEs need to be used. It is not absolutely necessary that every hospital staff has to wear a PPE, but those coming in contact with COVID-19 or our frontline workers, they have to mandatorily use these PPE. But that doesn't mean that the receptionist or even the ward boys, etc., have to wear PPE. And that's sometimes a misconception that everybody has to wear PPE. Safe injection practices like sharp management, etc., are very, very important. Similarly, safe handling, cleaning, disinfection of the patient's care equipment is also important. We have to see that whole environment of the hospitals or nursing home or any clinic needs to be kept well. Safe handling and cleaning of the soiled linen, and this is very, very important, that the soiled linen, soiled masks, soiled cap, and all the coveralls have to be properly thrown in as a bio waste. So standard precaution also includes the basic level of infection control, precautions to be used by all the patients at all the times, regardless of suspected or confirmed status of the patient. The risk assessment is very, very critical, for all the activities. That is, assess each healthcare activity and determine the PP that is needed for added protection. So now one other very pertinent question is how long the virus can survive and where and which state. So we have the amount of infectious viruses on any contaminated surface is likely to decrease significantly over 72 hours depending on environment conditions. And so there are various sources of contamination. You can see even the lift buttons or even the door knobs, cash collection or cash transfer, sometimes touching the face, touching nose, or even ATM machines are all these potential contaminant, and there we have to be extremely careful about using the contaminant. So this is the hand washing technique that all of us know, but this needs to be kept as in like a poster to wherever the possibilities of people washing this. And these are very, very important steps so that each part, the nail bed, the nail, the small crevices on the hand have to be cleaned well. And it takes minimum 2 minutes, and it can also extend to 5 minutes depending on where you are going to work and how you are going to touch. And this needs to be done before wearing the gloves, before actually touching any surfaces. So as I was telling, the coronavirus on the surfaces are very, very important things that we have to know. And this is why the metal, glass, ceramics, it can survive for almost 5 days. And food and water, it doesn't seem to spread through food or water. So keep in mind, bathrooms and kitchens are areas that harbor germs. So high touch surfaces to be cleaned daily, remote controls, game controllers, keyboards, computer mice, and very important contaminant is, or where the fomites are there, cell phones and landlines. The phones are very, very dangerous. Light switches, switch plates, doorknobs, doors, staircase railings, and all these places, these viruses can survive. And that's the reason, and I have given you a chart where at the aluminum surfaces you have 8 hours, and on the paper, glass, furniture, it can stay for almost 4 days. So preventing spread of infection at workplace is important, and these kind of posters need to be kept for the visitors. Do not enter the health facility if you have any of the following symptoms like fever, cough, and also shortness of breath. So previously, before COVID-19 came, the aim of staff and healthcare workers was to work to take care of the patients. But now, during COVID and after COVID, it is very important to take care of patients while taking care of self, because we need to take care of self. And just to give you a bad news that our task force head, Dr. Sanjay Oak, also was admitted, and he was quite critical, but fortunately he came out of that. He was admitted for almost 12 days and in ICU, and he's come out. So similarly, lots of healthcare workers have gone through real difficult times, but fortunately many have survived, many couldn't unfortunately survive. So we have to create a safe schedule and follow the schedule with full discipline. And this discipline is very important. And for OPD, it is very important that we have telephonic or telemedicine or teleconsultation which needs to be done. And this has really, we are fortunate that on the 25th March, the Ministry of Health has really made it possible that telemedicine is now legal, and there are lots of guidelines, we have to follow them. So we have to take control of all the appointments of the patients. We have to do a telephonic triage of severe, acute, chronic, etc., and ask detailed symptoms and is the patient's travel history and address. Many can be managed by on the telephone video call. We know that some of the backaches, neck aches that we can really treat, and all of us have been treating so far in last 3 months too. And at the same time, any reports like X-rays, some lab reports have to be seen online so that there is not much time which is wasted in the OPD later on. Preferably use OTC drugs or the drugs which are very easily available and without any much problem, so that the patients don't have difficulty in getting those. At the same time, keep the records. And now this Arogya Setu app which has come, which is extremely useful in triaging these patients And we also know from which area they come from, because it is linked to the Aadhaar card, and we know the background of the patient, especially if they are new. So basics to wear at work will be, as I told you at the beginning, mask, face shield, gloves, hand sanitization after each patient. And these are basic precautions which need to be carried, and we should not become overconfident while using this. There are different types of masks that we know. Simple surgical masks are good enough for general purposes, but we should have all the hospital staff, especially the reception and the ward boys, those who are dealing with the patient's x-rays and other thing, any investigations, etc., they must wear 3-ply mask. And for the doctors also, 3-ply mask is good enough most of the time. Only when they have to do some simple suturing, or sometimes even the patients who are suspected or non-suspected, when we are dealing with them, because some patients may be asymptomatic and we have to be wearing the PPE mask. And this mask, which are N95, which are very important. Again, there are types of different masks that are available. It is not necessary that all of us have to use high-end masks. So in the front reception duties, we have our co-workers or subordinates helping to find out the temperature measure, which has to be kept at a safe distance, and do infrared thermometer check. We also have to take the mobile from the patients to give it to the relatives. We have to do the hand sanitization, giving patient gloves, and very important to take the COVID consent, which is very important. That this COVID consent is important, because supposing the patient is not suffering from COVID-19 and doesn't have, is asymptomatic or whatever, in case if he becomes positive later on, he should not blame the clinic or your nursing home or the doctor that he has got this. Because this consent also is very important later on for a medical legal. And any kind of reports that he gets, we have to sanitize them, and we have to see that they are safe. So there are a couple of checklists for the receptionist. First of all, patient's registration, his travel history, his vitals, history of fever, cough, cold, loose motions, malaise, feeling weak, and some patient instructions. All these could be done by receptionist, so that your work becomes less. There are patient instructions given by the staff that only 2 patients are allowed in the reception area. Patients are requested to sit on the allotted chair. No mobile phones allowed with the patients. Patients are requested not to touch anywhere and use gloves throughout. So patient uses safe distance in waiting room also, and social distancing in the reception area that these diagrams or pictures show. So what are the care at the clinic that doctor needs to take? He has to wear either polyester, nylon clothes, which are easy to wash later on. Wear simple full sleeves clothes, easy to remove and wear. Hair should be tied if you have long hair, or especially for the ladies, and you have to wear cap on that. Don't wear any jewelry, no necklaces, no watches, and even the rings, which should not be worn in the clinics. And these are potentially contaminants, or take the fomites, which are very dangerous sometimes. Don't use any cosmetics, and feed an empty bladder and bowel. That means before starting your clinic, see that you can go to the loo and clean yourself, and also empty your bowel, because later on, maybe if you wear PP, it may not be possible for you to use the toilet for next 6 to 8 hours. Take your own water bottle, and this is very important. Sometimes we make a mistake that we share the water bottle, and that can be again dangerous place. Check temperature yourself, your own temperature, and your subordinates also. Change clothes in the hospital. Do not get your clothes to your home. Change that there and then come to the hospital, and keep your own clothes separate in the small cupboard or some locker, which also needs to be sanitized. Wear 3-ply mask while traveling, and N95 mask at the hospital. Wear apron or gown and food covers. Eye covers, goggles, or face shield also to be used. And now you may not be able to use the N95 continuously. So what we do is take 5 N95 masks and use the first day mask on the 6th day, so that we can rotate this using of this 935/95, so that you can also reduce the cost. We can also clean that, but you cannot clean it with the ultrasonic, etc., because it can electrify those things, because it is virus control, and that can cause the problems with the N95. Avoid touching the face, eyes, and cap, because there are certain ethics of wearing mask, and you should not touch it all the time. These are mask etiquettes. Social distancing for patients and relatives and colleagues are very important. Have food separately, and this is again important, that whenever you have to stage it where your lunchtime, so that you eat separately. The staff also have to see that every 10-15 minutes they separately eat. They do not eat together. Use gloves appropriately whenever needed. Of course, you can't wear the gloves when you are eating food. Repeated wash or sanitize the hands are important. So this is the general waiting area where you have to put a strap so that patients do not sit next to each other or the relatives. Keep only one finger pulse, BP apparatus, stethoscope, and pen. And that is very important, that you do not have many things on the table or wherever you are examining the patient. And sanitize these things repeatedly. And this is again done after every patient. Get examination table cleaned immediately after seeing the patient. Keep OPD floor, waiting area, and reception and tabletop door handles clean with sodium hypochlorite. Again, this is what we have to do. Supposing small spirit swabs or disposable swabs should be given, so that patients can clean that whenever they are using the doorknobs or they are using the lift buttons. Hand sanitation at reception on both entry and exit has to be done. Allow only one relative in the OPD. Ensure that hand sanitation of all the coming to the OPD, whether they are relatives or the patient themselves. Practice only your specialty and refer others. And this is important, because many times we also tend to treat other things and along with our comorbid problems. But this will ensure the number of visits to the patient to multiple doctors, eventually reducing the traffic at the clinic. Keep spacing in the waiting area. Remove all necessary items like books, newspapers, and these are important. Magazines, etc., should not be kept, because patients then unnecessarily tend to touch them. Keep windows and doors open. Keep them ventilated and avoid AC. And this is again very important, that you should avoid as much AC as possible. Normal ventilation with open doors and windows are anytime better than the ACs. Patients are given instructions by the staff. Patient uses safe distance in consulting, preferably online transaction of the cost when the payment should be done. Cash as much as possible should not be used, because again the soil nodes can cause problem. They should be kept in the envelope. The patient themselves count it in front of your cashier and puts them in an envelope and gives it. But as far as possible, the online transaction is always preferred. Again, the same thing should be done at X-ray protocols too. The technician, if he thinks that he can manage that, because it's not easy in the X-ray department to wear PPE all the time, but at least some precautions have to be taken, like what I have shown on the right side. And every X-ray table and cassette should be cleaned after the X-ray is done of every patient. The reception's duties are also specified. They collect the X-rays and keep them in the consulting room. The doctor should not, as much as possible, should not touch the X-rays of the patients. The cleaning protocols of the hospital includes spraying 15 liters of water plus 300 ml of 5% sodium hypochlorite. Spraying on the walls, floors, glass windows, chairs, and lifts are very, very important. So all surfaces are sprayed. No spraying on electrical equipment, wood, or fabrics. And this needs to be important, because there are possibilities alcohol based, and it is possible that it might catch fire. So cleaning protocol also includes mopping with 5% sodium hypochlorite diluted 10 times, and to be done before and after the OPD. Again, these are routine environmental cleaning which needs to be done. We have to clean, rinse, and disinfect the hard surfaces, and also providing disposable wipes for easy and frequent cleaning of these doorknobs, keyboards, etc. And these are very important. Finally, why should you take all these measures? because we have to prevent, and prevention is the best cure in COVID-19 situation. Anyone can be source of infection or spread. Some patients may not have any symptoms. Patients may already spread the infection before they develop symptoms. So treat every patient as a potential carrier and every surface as contaminated. COVID in healthcare workers, we have seen that more than 1 million workers or healthcare workers are affected across 200 countries. In India itself, more than 200 doctors have become positive. Some of them, unfortunately, have perished, and the casualties are rising. These are the China, USA, and Italy, some of the statistics which are shown. And in current situation, as late as 26 June of 2020, at 8 o'clock in the morning, there were 4,90,000 active cases in India, 2,86,000 were cured or discharged, and 15,301 deaths were seen in India. During last 24 hours also, 13,925 COVID-19 patients have been cured. That means the recovery rate has been outstanding. That is almost 56%. And that is what we are happy that it should reach 100% soon. How to wear mask is important. Before putting on the mask, clean your hands with alcohol-based hand rub or soap and water. Cover your mouth and nose with mask. Make sure there are no gaps between your face and the mask. Avoid touching the mask while using it. If you do, clean your hands with alcohol-based hand rub or soap and water. Replace the mask with a new one as soon as it is damp and soiled, and do not reuse single-use mask. To remove the mask, remove it from behind. Do not touch the front of mask. Discard immediately in a closed bin or bio-waste. Clean hands with alcohol-based hand rub or soap and water. Again, there are a couple of mistakes that everybody does while wearing a face mask, and this should be avoided at whatever cost. Mistake 1 is not washing your hands before wearing the mask. Mistake 2 is not covering your nose and mouth, and this is very, very common mistake. Touching or adjusting the mask from front, this is not absolutely allowed. Masking too late or removing it too soon are again dangerous habits that should not be done. And reusing old and dirty masks again can cause problems. So we should not do. And correct way is the first one, which we cover the nose and the mouth, and at the same time we can actually see properly. There is no fogging in case if you wear, because your eyes have to be also covered by goggles or face mask, and that is important. And they have to be as snugly fitting to the face as possible. All the other 5 are something which should not be done, and these are the mistakes. Now let's come to OT protocol. Whatever we have done is OPD so far, and OT protocol is very important because many places we have now started the elective procedures. First and foremost is that there has to be barricades in the operation theatre, which we always have. But now this is the corridor we have on the left side, barricade 1, 2, and the operation theatre itself. And in barricade 1, we have to change, the changing is done. And before barricade 1, we should go to the toilet, use it, and then only cover, because again you might be stuck inside in the PP for next 6 to 8 hours. So changing hand, sanitation, gloves, and again changing back is done in the barricade 1. Barricade 2, once entered here, you cannot go back to barricade 1, and that is what should be prohibited. And here, this is the place where you wear a PPE kit, and it is also removed when you finish the OT. So we have surgery staff duties and after surgery staff duties, and they have to be followed. The anesthetists, the surgeons, the assistant surgeons, the staff, all of them have to follow the same protocol, and these are important. So there is an algorithm for elective surgery, and this we must know, because all of us are slowly going to start. Some of the places, they have already started the operations, and that's why we have to be very, very careful about it. So, supposing if the patient with a fracture or who is scheduled for elective surgery is symptomatic, we have to do a COVID-19 testing, which now we get reports after about 12 to 14 hours. But there are now RT-PCR studies, antigen antibodies, the ELISA test, and we have new ELC-IC test, ECL-IC test, which gives a result in about 30 minutes. with a specificity of about 80% and sensitivity of 99%, which cost only about 600 rupees. That should be done so that in case if the operation is emergency. So see the patient's condition. If he is unstable, we have to shift him to the ICU and do some kind of temporary stabilization of the fracture or plaster and postpone the surgery. If the patient is stable, of course, you can go ahead with the operative procedure. And if the patient is asymptomatic, which are actually the dangerous patients because we really don't know and sometimes we tend to be overconfident managing them, we have to find out the travel history and the contact history. If it is positive, again, we have to follow the same protocol as a symptomatic. But if the asymptomatic patient does not have any contact history, and if we get a chance to do a quick antigen antibody test, we do that, and if everything is okay, we can go ahead with doing the surgery, whichever is needed. We can also use our drills, we can use our saw cutting machines, etc. But in case if it is not possible, we have to think about traditional conservative methods to start with and maybe postpone the surgery. Again, there are some do's for the orthopedic surgeons which are extremely important. Consider each case admitted in the hospital in and around contaminated zone as COVID-19. And this is a very important dictum that we have to follow. Screening should be done for all patients visiting the hospital. Consent should have information that COVID-19 could be transmitted from any of the other admitted patients, maybe asymptomatic or in incubation period of the disease. Follow religiously infection prevention and control measures, and these are very, very important measures to be taken. Outpatient visits should be reduced. Telemedicine consultation should be encouraged and should be done nowadays. Conservative treatment should be the first line of treatment except for those with the red flag signs. Structured communication should regularly be organized between all stakeholders for pre-surgical planning and operation thereafter. OT environment, anesthesia, surgical plan should be modified to minimize the spread of infection. The surgical team should consist of experienced surgeons and not trainees, because we have to reduce the time of surgery at whatever cost, and look for the opportunity within the adversity. And there are certain don'ts which have to be mandatorily followed. Do not neglect the precautions for personal protection. Do not see any patient who has not been screened at the hospital. Do not mix non-COVID with COVID suspected cases. Do not mix the isolation areas for COVID suspected and COVID. Do not be over-enthusiastic in advocating surgical management. Do not bypass the workflow or OR for COVID positive cases. And do not waste time. Utilize it for consolidating your practice, giving due consideration to education and research. And this is again a floor plan in COVID operating area. We have an entry corridor, exit corridor, and at the end, at the down bottom is the waste disposable bag. So we have to see that all these places, whether it's an ante room or exit room or the operating room, basic minimal precautions of infection control have to follow. And what are the precautions during surgery? Use an operating room with a negative pressure environment. And if it is not possible that every OT cannot be changed to negative, then at least your air exchanges, the positive air exchanges should be more than 20, if possible up to 30, and we have a separate access. Airborne spread is a concern during aerosol generating procedures. So it is also important to understand the airflow within an operating room and have a proper equipment and protocols in the place to limit the spread of infection in this setting. Anterooms in which to put on and remove the protective equipment should be available or even constructed adjacent to the operating room. Again, use disposable surgical items, protective equipment, use double caps, N95 mask, medical goggles and boots. Minimize entry into and exit from the operating room during the surgical procedures. Allocate time between procedures to allow staff and the operating room to go through proper decontamination procedure, because sometimes we generally come out, have tea in the ante room or in the doctor's room, but this has to be now totally stopped. We cannot do that. We cannot take these frequent stops in between the operation, and we have to be very careful. So there are protocols during orthopedic surgery, and this has to be again followed. Pre-operative anesthesia consultation via video consultation by a member of anesthesia team. And this is a very important team that we are dealing with. They have to be as careful as the surgeon themselves. Regular consenting and special COVID consent as directed by the authorities. Avoid aerosol generating procedures by anesthesia team. And this is when especially the general anesthesia given. So use blocks whenever it is possible. And fortunately, we can use the blocks in most of the limb surgery, excepting for sometimes spine. But that for that also now they are doing erector spinae blocks, which are helpful in doing the spine surgeries too. Follow government guidelines on screening. Prefer to have 2 negative swabs and antibody tests. Use negative pressure room where possible. Check for all the requirements before surgery. No or minimal door opening should be done. Surgical team do not enter the theater till the time induction is being done, specifically if the intubation is being done. So we have to wait till all that intubation and the patient is actually given anesthesia and the anesthesia team says, okay, then only we enter. Minimize people in the OR. Maximum of 8 people to be there in the theater, including anesthetists, the surgical team, the nursing and the technicians. Patient should be double masked if regional anesthesia is given. All members of surgical team to wear N95 mask. Avoid aerosol generating splash generation method during surgery. So avoid pulse lavage, high speed bursts, use closed suction devices. And that is what is very important, especially in our joint replacement surgeries. Use of absorbable suture material wherever possible, because if you use that, then the patient again need not come to do dressing or suture removal to the hospital. So that you have to minimize their visits to the hospital or clinic. Patient should be monitored for 30 minutes after the end of the procedure in the same operating room. And this is important before he is shifted to the room or ICU. Cleaning of the operating room begins 30 minutes after the patient is wheeled out to let any remaining aerosol to dry up or clear. And this is extremely important. We have to wait for 30 minutes and theater has to remain closed for 4 hours before the next case is taken. And this is a general floor plan for perimeter of the hospital. It is for small or medium sized hospital. We can have a emergency room, the screening booth, and this is how the screening booth looks like, where the patient is really screened before the emergency room. And this is how the screening stickers are given to the hospital staff to demarcate them from the patient and patient relative. And this is the triage area, which is again very important for a middle-sized nursing home or a hospital. This is a floor plan for the emergency room of the hospital divided into 3 zones, in which we have a PPE donning room and doffing room. And it is extremely important that we have to have a protocol. We have 12 or 14 points in which the doffing is done. And again, if you don't do a donning or doffing properly, it can lead to problems. And there should be some kind of supervision, some kind of training needs to be given so that this donning and doffing is properly done. Clinically, we should have a COVID negative area, a CT scanner if it is there, good. If it is not there, we can have a positive area or suspected area, entry and exit of COVID negative zones, entry and exit of COVID suspected and COVID positive zone. And let me tell you, all these precautions are necessary. It will, of course, increase the cost of our therapy and it has to be shared with the patient. And if there is an 80 to 100 bed or 80 above bed hospital, then we need to have a floor plan of the complex, which have again different areas which has to be followed properly. And again, surgical team, we have to take protection. We see these kind of masks, which are very, very important. They could be, supposing you have mask, ready-made also can be done. You can also see the patient anesthetist who is behind the screen also is wearing mask and also a face shield. And these are all important precautions. But again, after all this also, we are still, we don't know lots of things about COVID. We really don't know the virulence and pathogenicity of this virus. Some say that the virulence in India has come down. Let's hope that it is coming down, and let's hope that lots of patients are becoming better and they do not go into a very bad storms that are viral storms that are there. The effectiveness of different modes of transmission, we really don't know. The proportion of mild and asymptomatic cases also we don't know. The ineffectivity During infectivity, during the incubation period, and during recovery also, we really don't know. Impact of individual or population-based preventive measures, we don't know. The risk factors of severe illness besides age and comorbidities, we are not aware of. The effectiveness of treatment regimen also not. So friends, at this juncture, there are lots of ifs and buts. There are lots of challenges which are still remaining. Lots of things are emerging new. Lots of newer tests, the newer treatment. But we really are waiting for a 100% sure shot treatment for COVID, and we also are waiting for this vaccine, which probably will be available after 6 months. But let's hope that this will come out and finally will be victorious. But I'm sure and I'm hopeful that hum honge kamyab. So friends, I must thank Vidarbha Orthopedic Society team who have done this, Dr. Sushit Babulkar and Swapnil Keni who have helped me to make this presentation. And first and last, that follow these guidelines are very important, and these are important for patient safety, for hospital safety, for your safety, and for your family safety, and finally for the nation's safety, that all of us have to follow these guidelines. Thank you very much.
Thank you, sir. Excellent presentation and very informative. So I think we have very expert panel here. Professor M. Rai sir, Dr. Golok Behari Maji, Dr. Protyush Chatterjee and Dr. Rajib Chatterjee sir. So any question from the expert panel?
Yeah.
I have one question.
Yes, Dr. Rai. Hello.
Particularly during OPD practice or in your clinic practice, hand washing for between two patients. If you see, if it is 2 to 5 minutes, it is too lengthy, because if I wash it with my soap for 23 seconds, it is believed that the outer protein part of the virus that is destroyed. So can it be shortened, or can we recommend that?
Yeah.
That is number one question.
Yes.
And I have another point about the sanitization. Sanitization, we use the sodium hypochlorite, but
yes.
a question has been raised about the carcinogenic effect of that. Okay, what about your recommendation nowadays?
Dr. Roy, your apprehensions are correct about sodium hypochlorite. It's a chemical, and as you know, any chemical and every chemical under the sun has potential cancerogenic this thing. So probably lots of more research and study needs to be really done to definitely have that correlation between hypochlorite and carcinogenic thing. But as of now, this is the safest, this is the cheapest, I would say, because it is reasonable cost, and as far as possible as a disinfectant, it has been proved as good. Other things like formalin, etc., we have found out it is much more dangerous. We can't really use it again and again. It has lots of irritant properties, and it can also burn your eyes, which can also have other problems also. So far, we have got this as a very good, cheaper solution, which is available. I think little more research can tell us about real correlation between it and cancer. About your hand washing, as I told in my lecture also, is that 2 minutes of hand wash is important. See, all of us as surgeons were in the beginning, before going to the OT, we were taught, and in fact, a lot of places have timers, and we were taught that 5 minutes of hand washing is important. Okay, and this is actually generally followed everywhere where the surgeons are operating. Some of the people do take some shortcuts, but they are not really advisable. So similarly, first time when you wash your hands, especially the surgeons and the hospital staff, we are actually coming in contact. These are very important protocols, because this is the surest way of contaminant and surest way of passing the spread or spreading the problem. So see, you know what happens is that supposing you say 2 minutes, some people cut down to 1.5 minutes, and then later on people think that our surgeon is only not washing it for much, about half a minute. Then what happens? It's a habit which is cultivated in the staff. So in order to cut short that whole thing, these posters need to be put, and we have to tell your staff and your healthcare workers that these are mandatory things, okay? And this is going to safeguard not only you, but it will also reduce the spread of infection. So I think these protocols, we are tending to be little overconfident and not taking the chances. That's the reason why our Prime Minister also has said that negligence has caused problems overall in increasing the spread of disease. So I think it is all of us seniors should mandatorily tell your juniors that these are very important protocols. So please don't cut corners. Please do not try to take chances because it is not in your interest.
Can I make one comment, Ram?
Yes, sir.
Please, Dr. Protyush.
My comment is about the use of hand gloves in the clinics. You before that hand washing. You said 5 minutes hand washing.
No. I said 2 minutes minimum.
Five. I mean, hand washing in the operating theater and in the clinic have got two different perceptions.
Yes.
I don't think when seeing a patient in your clinic, you don't need to wash your hands for 5 minutes or 2 minutes seeing each patient. 20-30 seconds, as Dr. Professor Rai has said, probably it's impractical also to wash for 2 minutes. Okay, that's one issue. The second issue is about using a pair of hand gloves. I have seen and I know many doctors who wear pair of gloves in their clinic. Now, my point is, if you want to use gloves, fine, but these gloves has to be changed every time you see each patient. It's it's absolutely wrong way to wear a pair of gloves and see 10 patients in your OPD. This concept the doctor should have this concept. Wearing a glove, fine.
I agree with you.
Wearing a gloves, every patient, you change your gloves.
I entirely agree with you. And there are autoclavable gloves which could be reused also 3-4 times. So we can use that definitely. And I entirely agree with your comment.
Rajib
Chatterjee, sir, please.
After each patient, we
Unmute,
have to
sir.
sanitize your table. We have to take care. Okay. So each patient is an individual. I know this is going to increase the cost, but wherever possible, we can reduce the cost. But these are very important. We can't really reduce the cost by using the same. It's like whenever you are a restaurant, they wear same clothes, same thing. That should be really.
Yes, Rajiv, unmute yourself and then speak. Rajiv, unmute yourself first.
I'm trying to. Okay, now it's come on.
Yeah.
The other Rajiv wasn't allowing me.
Yeah. No, now done.
Okay, done. So one important point I would like to know is contact tracing among healthcare professionals.
Yes.
What is the protocol? This is something which is not being done at all. So
Tell me again, Rajiv, I couldn't hear you.
Contact tracing among healthcare professionals.
So see, now this is a very important point that you have talked about. And see, there are different protocols for everything, and that has been discussed time and again. There have been papers only on hand washing, about wearing gloves, about contact tracing, about social distancing, and also donning and doffing of the glove, of the gown.
My question is very simple. You are a healthcare professional. You have been exposed.
Yes.
At what point of time would you get yourself checked, even if you're asymptomatic? Do you need to get yourself checked even if you're asymptomatic? Simple questions.
Yeah, I understand your question. So contact tracing, I know what you are asking about. So basically, all of us are vulnerable to getting this, okay? Because we are coming in constant contact with the patients all the time. So we have to be extremely taking care of ourselves. So I would suggest really after your OPD or after your whatever things that you do in the clinic, you have a bath if possible in the clinic itself, change your clothes and then you come out, okay? Because you are vulnerable and once you get affected, your family also can get affected, okay? So if that is not possible, at least go. Now I have an anti-flat where I go outside and even anybody comes to my house, they have a bath there, change of clothes, and then enter my house. Okay, because I am orthopedic surgeon, my wife is a gynecologist, my son is spine surgeon, my daughter-in-law is a gynecologist. So all of us are potentially vulnerable to getting infection. So now for last 3 months, my hospital is not closed for one day also, and we have been following strict protocol. Touch wood, we haven't had any problems. So we have to take certain precautions which are absolutely mandatory because
No, I'm
there is
talking
no
of the
choice.
swabbing. Swabbing,
Because-
basically healthcare professionals, nasopharyngeal swabbing. Now, this is something which is, I'll tell you my personal experience. So I'm just share with you.
Yeah.
My registrar tested positive 8 days ago.
Yes.
I've been trying to find out an exact protocol because somebody says 5 days, somebody saying 9 days. The government, I downloaded the ICMR protocol. The ICMR protocol says that you have to be a high risk. The high risk again is a very gray zone. They are saying that in a room for more than 15 minutes, direct.
We have lost you. Your video is frozen.
I think there is some network issue. So, sir, role of hydroxychloroquine in healthcare professionals.
Yeah. See now, Rajiv, this is a question which is very, very pertinently asked. Myself had a lot of problems with HCQ. I had real cardiac problems when I took HCQ. So I am little scared about HCQ. I had severe bradycardia, I had xanopsia, all kinds of problems I had with one single tablet. So I will really not recommend it to people who are above 60 or people who are having comorbid problems. It should not be randomly given to everybody. I think all those people who are probably going to take HCQ with due precautions, they have to take their ECG. They have to do it under the supervision of doctor or if possible with a cardiologist. And I can assure you that it should not be randomly taken. Just like any arsenic tablets which have come in homeopathy and there are certain tablets in Ayurvedic, I think you and me are not going to take those, right? So even this HCQ has not 100% proved that it is going to prevent these problems at all, okay? But, and I would also not recommend it to be randomly given to all our staff members. We haven't done that, and I would not like to.
Rajiv da, you are back. Please continue.
Sorry, Amar,
Sorry, Rajiv, we lost you.
Sorry. When do?
So, are you talking about the incubation period?
No, I'm asking when should a healthcare professional get himself tested? What are the exact protocols regarding when, and when do you think you are a high risk
Okay,
for transmission?
Incubation period for this is 2 to 14 days. You know, me know, everybody knows.
Yeah,
Okay.
but
So that means everybody. Now there are lots of asymptomatic carriers. They get well also without doing any test. Okay, and this has happened in my family. My niece and her whole family, they are also doctors. All of them suffered from COVID. The daughter, who is an anesthetist, her test was positive on the 3rd day, and then they did not do anybody else. She got herself isolated, and everybody. Her father is a gynecologist, mother is doctor, and brother is also psychiatrist. So one after the other, in next 10 days, everybody got infected, COVID positive, but 3 of them had never any symptoms. Okay, so that's why it is a gray zone, as you are saying, 100% if anybody is going to be liable to have or suspected. So we cannot say asymptomatic patients may remain asymptomatic also, and they may not be infective too. May or may not be infective. Okay, so there are these gray zones. These are not known to me. That's why I put the slide at the end that we really do not know the virulence. We do not know the pathogenicity of this disease. We do not know how this spread is really done. We really don't know how it is going to transfer to other things. So there are lots of unknowns in this. We cannot pinpoint and say in 5 days, okay, you are uninfected. But here, now in Mumbai itself, with so much of disease being spread, we do not do COVID test of everybody. We do not do, supposing if I am infected and if I have some symptoms, I do it, but not necessarily my family's test is done. Okay, unless we think that there are some possible symptoms which are there. Otherwise, my family is not done. We don't do the test. Okay.
Can I answer Rajib's question, Rajib? Can I try to answer your question?
Yes, Pratyush sir, please. Pratyush sir, please.
He asked about the protocol of supposing a doctor has contacted a patient who was COVID positive. He came to know. And how long should we wait to get ourselves tested? That was your question, Rajiv, am I right?
Yes, sir. Yes.
Well,
yes,
as Ram has said, 2 to 14 days is the incubation period, but according to ICMR recommendations, 5 to 7 days after contacting one person is the right time to get yourself tested.
But at the same time, it is not necessary if somebody is asymptomatic to do the test, because that test mostly will be negative. Mostly.
But the worry is that you can become a super carrier. See, this was happened in China, the last outbreak. That's what I'm worried about the future.
Rajiv, we are talking too much in future. We are managing and we are now combating this. The war is there. We have not yet won the war. Yeah. We are not talking. We should not be talking about what is going to happen 2 months. Yeah. Just now also the situation is so bad that we have to just combat this. Thinking about super infection later on.
What I'm trying saying is that's what I think this is what we have to take as healthcare professionals is contact, trace, contact.
See, Rajiv, I'll tell you one thing is that in Bombay, at least there is not a single case with again super infection, or there is a resurgence of this thing. Not a single case where we have got almost about 20,000 people infected.
So I'm talking of the asymptomatic carriers. That's what.
Yeah. But listen. Now everybody should be taken as a COVID positive unless proved otherwise. Okay. Absolutely. So anybody who comes in the OPD also, you should think that he's COVID positive. Think whether he's symptomatic or asymptomatic. So treat him and take all the precautions possible as if he is COVID positive. So think whether he's symptomatic, asymptomatic, whatever. And in Calcutta or in Mumbai, the pollution is so much, you will see everybody having some dry cough or sore throat. Practically everybody. So you can't keep on doing the test, and I don't think it is right, because COVID test is not 100% sure. The sensitivity and specificity is about 80%, not even 80%, less than 80%. So that also doesn't say that somebody is negative. Really, he can be COVID negative and plus could be false negative too.
So there is one question. So whether we should use 2 3-ply mask, 1 N95, 1 3-ply mask, or 1 N95 mask while doing orthopedic procedure.
So procedures, I think that if you are doing even a small procedure, N95 is very, very important. Okay, you can for the OPD and other things, 3-ply mask is good enough. Okay, but N95 or similar kind of one without the expirator, with the expirator, with the respirator, whatever, but that is mandatory. I think that is the only probable precaution that you should be taking. Any procedure, orthopedic, it's a minor or major. Only close reductions, maybe you won't use it.
Golok sir, any question from your part? Golok sir, please unmute.
And we just had one more webinar recently, and in which Ganga Hospital in Coimbatore, his anesthetist head had come along with me, Bala Venkat, and they have in last 3 months done more than 1,000 procedures. Most of them were of course emergency, and he said that aerosol generation thing with orthopedic procedure, he said it's not a myth, but he said you should not be so much scared because the infectivity of blood or those aerosols which we do, pulse lavage, etc. also may not be that scary because they have used it. Of course, they don't use the pulse lavage, but he said that aerosol generation, because the saw cutting or with the heavy duty drills also, they have not got a single healthcare worker. They have got about 1,500 people working for them. They have a team of more than 300 doctors. In last 3 months with 1,000 procedures going on, with so much OPD, about 20 to 30,000 people whom they have screened and seen, they haven't had a single healthcare worker who is positive. And that's a good sign. That means they have taken adequate precautions. At the same time, I think these precautions are extremely important. These social distancing, face mask, sanitization are things which are absolutely important. OT protocols, so we know, and we are going to follow them. But right from taking the temperature of anybody coming inside the hospital, reducing the people coming to the hospital, taking those hand sanitizer and wearing gloves. These are simple precautions, but which have to be followed by everybody who is going to come in contact with patients. And that, he says, is probably what has helped them in Ganga Hospital. And that was a real good, comforting statement that he made, that we've got so many people working, and fortunately in last 3 months, that doesn't mean that tomorrow they won't have anybody.
Kiran, you have got something to say about HCQS use.
Who wants to say?
Yes, that's one comment of HCQs. Apart from the cardiac toxicity, the HCQs have a awkward side effect on particular children and young adults. That is the EPS, extrapyramidal syndrome. So that is a very awkward. There will be rolling of eyeball, there is retraction, that is like dystonic symptoms. So we will be very careful while giving HCQs amply on everybody.
Yes.
So this EPS, you can go to the PubMed and you see that there are lots of papers on side effect as EPS on children and young adults. So we will
as far as EPS is concerned, this is mostly reversible. If you stop the drug, it comes back. Yeah. But
yes,
point is, I have got a question. We have been using HCQS to our rheumatoid arthritis patients for months together, not for weeks, months together, even for years. You have never experienced any complications on this part.
This is common in children and young adults, but usually patients with autoimmune disorder, this EPS symptom is less.
So there is
one question may I ask. This is regarding the OPD based COVID testing. So because in patients for waiting for getting operated, what is your take on OPD based COVID testing? Suppose a patient comes with a COVID negative report which is 5 days back or 7 days old, because now government has allowed OPD based testing. So how are you going to tackle that situation, or again do you repeat the test admitting the patient in your hospital?
Yeah, I think 1 day, 24 hours before, we have to see whether the patient is COVID negative. That is important, because 5 days or 10 days old COVID positive or negative test does not mean anything.
Yes.
If you are going to do an elective surgery, it is mandatory that at least 24 hours we should know before the surgery that patient is COVID negative. Because then you are subjecting everybody in the team to have potential infection. You know,
there is a practical problem, Ram and or no.
Yes.
I recently had one patient who had met with a road traffic accident. I had to do fasciotomy as an emergency procedure before the COVID testing could be done. And then he was admitted and the COVID was done. He was negative and the definitive surgery was done. Now he went home. But the fasciotomy wound needed a secondary suture. By that time, it had passed 2 weeks. 2 weeks is my hospital said 2 weeks is the deadline. Within 2 weeks, had it been done, we would not have done a second COVID test. But because he is coming after 2 days, after 15 days, if you are going to put him in the theater, then a second COVID test has to be done. So to be practical and safe, I think 2 weeks time should be given for each COVID test.
Sir,
yes, what is your hospital
but this is your own personal view. I do not endorse, and there is no clear-cut guidelines on this. But if you have to safeguard yourself and your staff, I think I will go ahead with doing the test, even if it is within a week. It doesn't.
Actually, this is not my personal opinion. I took the opinion of the experts in.
But nobody in Bombay will be ready to accept this view for 2 weeks.
Past, had it been within 2 weeks, we do not know much about this.
That's precisely I said in the beginning. There are lots of things which are unknown about this disease.
One comment from Rajib.
One of the reasons, and then don't take chances with yourself. You know, the patient.
No, little answer to your little query. The COVID tests are done at 2 types. One is the RT-PCR. The other one is the gene expert. The other types, which is the TrueNat. The one you're talking about, the rapid one, the TrueNat one. Actually, if you look at sensitivity and specificity, the TrueNat actually looks at the live viruses. RT-PCR looks at dead viruses also. So even if you have a COVID positive, you might be looking at a dead virus. So if RT-PCR doesn't give you a very good idea, so the TrueNAT test, the Gene Expert test actually gives you the live virus, the fastest test, which is costly, but actually is much more specific and sensitive.
Okay.
Little answer to your question.
I will add to that, Rajiv, that last week ICMR has allowed the ELISA test, which is called ECLIC. Okay, which is the ELISA test, which is a luminescent test, which is with a sensitivity of almost 99%, with sensitivity of almost 80 to 85%. You get the result in half an hour, and it costs 600 rupees. Okay, and this is as good. And Mumbai, everybody has started doing this now, and we are very happy so far.
So one little question to everybody here. All of us been talking about starting routine surgeries. My real worry here is if, let's say, the patient gets a COVID post-op somehow, the cytokine storm that hits you is like trauma. Why do you do a DCU? Why don't you do a ETC? It's because of those interleukins. Your surgery has started the interleukin storm anyway. And then the patient gets another interleukin storm after that. So are we safe doing really routine surgeries? My question to everybody.
No, but this is again, Raju, it is hypothetical and it is quite...
Sir.
No, listen.
This is from...
So these are possibilities, okay?
Yeah.
Patient becoming COVID positive post-op, or maybe in the interim period, that interval, incubation where he is not really sick. There are possibilities, yes, okay? And there are possibilities of anybody, including the doctor who has done the surgery, can have this cytokine storm. Anybody can have, okay? So this is a virus which does not spare anybody, rich or poor, surgeon, intelligent, educated, doesn't matter, so it is going to hit everybody. That's what I said. Our own, the task force head, who was a dean of our KM hospital for 4 years, and who's been a very renowned surgeon, he is a task force head right now in Mumbai, and he was admitted in ICU with a cytokine storm. In fact, it was really lucky, and we are really happy that he's come out of that. So cytokine storm hitting the patient or doctor is there. That back of your mind, you should always be scared of. You cannot really stop it. In fact, one gynecologist, my very close friend's wife, she was okay till 10th day. On the 11th day in the hospital, in fact, when she was going to be discharged, she again had the problem, cytokine storm, and she had to be ventilated. Okay, so this can happen. And these are, so generally 7th to 10th day is what people are saying, that you can have this problem and you can really go into a real deeper shit.
So my question is, should routine surgeries be, unless absolute indicated, somebody's already hobbling in pain, should we just be postponing a routine surgeries if possible? I want a clear message.
I would say, if you take precautions, if you know that a patient is COVID negative 12 hours before, and as what we discussed with Ganga Hospital team, who have done 1,000 surgeries, out of which almost 300 to 400 surgeries were planned surgeries, including joint replacement, spine surgery, and whatever precautions that they have taken during anesthesia, intubation, and again, positive pressure in the operation theater. They don't have a negative pressure, but they have air exchanges which are extra all the time. So all these are precautions.
Okay.
I think that we can definitely start.
Okay, that's
I think we should be able to start. The message will be, I have been doing elective surgery, let me tell you, for last 1 month, okay, with adequate precautions. And emergency surgeries too, obviously. Emergency fractures, all of us are doing. But even elective. So what is the difference between emergency surgery and elective procedures? The extent of the surgery, the severeness of the surgery is more or less same.
Rajivta is talking about patient safety also.
I'm talking patient safety.
Giving them a second hit to patient.
Can I just do it after 1 month? What I can do after 1 month? What should I do today?
See, something, if you can avoid nothing like that, if the patient is willing to do it, if the patient is in a state that it is not really emergency, you're not talking about you're not.
That's my message. That's my message, I think. What's happening is that general push has been now to go for the routine surgery. I think still we are not ready till we get to know what we're dealing with.
So
do the routine work, which are absolutely required. Yes, a knee replacement who's completely wheelchair bound, definitely. But somebody can wait for a month, month and a half, postpone. That's what I think the message
No,
is.
but that again, Raju, it depends on the consent of the patient. You have to explain
It's
the
what you-
patient the risk of getting operated now vis-a-vis what problem that he has. Okay, so for some patient, he may think that it is very emergency. For you, it is not emergency. You
It's how
understand?
you
no?
explain, it's
So
how you
that-
explain to the patient. And
Yes.
that's what we have to learn, to tell the patient very specifically and
Yeah.
exact. You have to tell them about a cytokine storm. This is why, because my 39-year registrar is at the moment in ICU battling a cytokine storm. And I'm seeing him every day. And I really feel bad.
I entirely agree. And there are 10 doctors who are eminent doctors in Bombay who are in ICU right now.
Absolutely. So why?
No, so
why
this
take-
can happen to anybody.
Why take a risk?
And we can't say that they have used the defective PPE kits
Absolutely,
or they have
absolutely.
not taken precautions. They have
Absolutely.
taken precautions.
With precautions is that situation. So
In one of the
Right.
hospitals,
Sir,
Bhavati
do
hospital,
this
4
thing
of the ICU specialists are there, pulmonologists are
I
admitted.
know.
Exactly. So do
Yeah.
you think that this will dramatically improve by 1 month? I don't think
No,
so.
no, 1 month. This is what we are looking at is, or no, what we are looking at is a downswing.
Yes.
With a huge amount of what we're looking at. I've been speaking to pulmonologists all over the world, my batchmates. The basic problem has been happening is the viral load.
Yes.
So it's just not a single, it's a viral load is also important. Now, with a larger number of cases going up, your viral load is going up in the community. Once the viral load starts coming down, your cytokine storms also will start coming down. Then it becomes easier for you to open or to do your surgeries. My colleagues in UK have not started, my own compatriots have not started doing joint replacements.
No, that is fine.
Sorry, Rajiv, in UK, my friend is getting operated after 3 days for his knee.
Some of the major centers have not opened yet.
Sir, I think we
Anyway,
should
let's carry
include
on.
the
Let's
point
carry
in our consent form
So-
that the patient might get infected.
Absolutely, that's very important.
hospitalized.
That's
That
absolutely
thing has to be explained to the patient and patient.
There's no
Absolutely.
question about
Has
it.
consent.
All of
Yeah.
us are first of all going to look after the patient safety and your safety and the hospital staff safety. There's no compromise on that. There's no
Absolutely.
question about it. So we have to balance between the patient's emergencies procedure and the safety of the patient. So we have to explain, we have to see, this is a difficult times, Rajiv, and all of us know that, and we have to surmount that. You cannot say that in 1 month I'll be able to postpone and do the surgery, because we really don't know the answer. We don't know the end of the tunnel. We don't know whether it's going to be November or December before we actually
Yes.
start full-fledged working that we used to do by December, January. So this is a very pertinent question,
Don't know.
and nobody has 100% answer for it.
And nobody's answer. Nobody has answer. I know.
Nobody has a 100% answer, but
I think
see,
one last question to all expert panel. So we are doing a pre-operative COVID test. So how many of you suggest a post-operative before discharge COVID test to your patient? Starting with Rajiv sir. Rajiv?
No.
No. Ram Prabhoo sir?
no.
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 So some patient, yeah.
See, most of my patients have been discharged in 4 or 5 days, and they haven't had fever. One person who had got one procedure done on the back, okay, after 3rd day he had fever, and then that fever was thought that some kind of subclinical infection or something, given antibiotics, etc. On the 10th day, we got his COVID test done, which was positive, but he didn't have any other symptoms excepting for the fever. And on the about 15th day, he became all right. Okay, so that is one patient, one Sardarji patient I remember. That's all.
Yeah. I think we can go with our next talk. A very good interactive discussion was there. So Kiranda, are you ready with your presentation? Yes. Please share your screen.
Excellent session. I think the discussion was superb.
Yeah.
Thank you, sir, for your nice time.
So good evening, everybody. This is a brief recapitulation of the pathology and medical management of osteoarthritis. So osteoarthritis is basically a painful degenerative joint disease which involves the cartilage. It's not an inflammatory process per se. The articular cartilage its main function is to absorb shock and provide a frictionless movement to the joint. And hyaline cartilage is the most common type of cartilage. Hyaline cartilage consists of a low density of chondrocytes and a large extracellular matrix, that is ECM. Its The constituents are mainly water, 66 to 79%, and I'm not going details regarding this composition. So under normal conditions, the physiologic homeostasis of the articular cartilage is driven by the chondrocytes. The chondrocytes produce the structural matrix containing collagens. Primarily, this is collagen type 2 and also proteoglycans. So there is a balance between the cartilage matrix synthesis and the cartilage matrix degradation. So when there is an imbalance between these two, so there is a damage of the cartilage starts, and this is a cascade of events, and this is a progressive disease. So microscopically, at first there is increased water content of the cartilage, and there is easier extractability of the matrix proteoglycan, and there is loss of proteoglycan followed by sense of defect in the articular cartilage. The cartilage becomes soft, cartilage becomes deformed, and there the damage to the chondrocyte starts. And then after that, the release of the enzyme, that is interleukin-1 and MMP starts. So interleukin-1 is a potent pro-inflammatory cytokine which is capable of inducing chondrocytes and synovial cells to synthesize MMP. MMP is matrix metalloproteinase, is responsible for degradation of the articular cartilage. Interleukin-1 also inhibits synthesis of collagen type 2, proteoglycans, and growth factors B, stimulated chondrocyte proliferation. So there are some causes of osteoarthritis. So we call them the secondary way. And for the primary way, these are the risk factors: the obesity, the increased joint loading leads to osteoarthritis, the family history, and the bone density also indirectly may induce the increase of the osteoarthritis changes. But there may not be a simple cause and effect relation. The articular cartilage is fast access to be affected. There is erosion first, often central and frequently in weight-bearing areas, followed by fibrillation, which causes suffering, splitting, and fragmentation of the cartilage, and collagen fiber split, and there is disorganization of the proteoglycan-collagen relationship. The bone is eburnated, that is, the bone surface becomes hard and polished as there is loss of protection from the cartilage. Cystic cavities form the subchondral bone because eburnated bones is brittle and microfracture occurs, and there is venous congestion in the subchondral bone also. The changes of the synovial membrane. The synovial membrane undergo hypertrophy and become edematous, which can lead to cold effusions. Reduction of the synovial fluid secretion results in loss of nutrition and lubricating action of the articular cartilage. The capsule also undergoes fibrous degeneration, and there is low-grade chronic inflammatory changes in the capsule. So OA mostly affect the weight-bearing joints, the spine, the hands, the hips, and the knees. And incidence prevalence is the second most common bone disorder in India. So these are the risk factors of osteoarthritis: old age, obesity, females, family history, occupation, and trauma. These are the common signs of the osteoarthritis. There is a bony enlargement or osteophyte or bony spur, limitation of range of motion, there is capitation on motion, there is tenderness on pressure, pain on motion, there may be cold joint effusion, and malalignment or joint deformity. And the symptoms are joint pain, morning stiffness, gel phenomena, buckling or instability, and loss of function. These are long-term complications of OA are chronic pain, difficulty in performing daily activities, joint deformities, impaired balance, increased risk of falling. So the inflammation is not a normal feature of osteoarthritis. Is not a normal feature of osteoarthritis, but when there is cartilage destruction and there is debris that can cause the synovial inflammation. So the diagnosis is mainly clinical, and on imaging that is mainly on X-ray. MRI is not usually required, and we all know the Kellgren-Lawrence classification based on standing AP, X-ray, and the lateral X-ray. The American College of Rheumatology guidelines says that the goals of osteoarthritis management are to control pain and other symptoms, to minimize disability, and to educate the patients about the disease and its therapy. So the managements are two types. There is non-pharmacologic and the pharmacologic. The non-pharmacologic treatments are also very important. There is the weight loss to keep BMI less than 28 at least, aerobic exercise, psychosocial interventions, thermal agents, walking aids, and on pharmacologic therapy. The first comes the topical NSAIDs, then the oral NSAIDs, the tramadol, intraarticular corticosteroid injection, though the role is the scope is very limited, and also viscosupplementation. So these are the stepwise approach for OA. There is the exercise weight reduction followed by NSAIDs, NSAIDs plus supplements, plus then opioid therapy followed by limited scope of corticosteroid injection, and then the viscosupplementation, and finally the surgery. Surgery also of two types. I am not discussing of the surgery. So, but the current drug treatments are limited. The pharmacological options, they don't provide adequate pain relief in the late stage of osteoarthritis, and there are significant side effects of the pharmacological agents which commonly we use, and the treatment may not be suitable for many people, and there are poor achievement of clinical remission. So these are the pharmacology therapy. Stepwise, we can use these. The acetaminophen or the paracetamol up to 1000 milligram can be used 4 times daily. Then if paracetamol fails, then NSAID, but there is a threefold risk of particularly GI complications. And opioid analgesis can be used as a short-term basis on acute examinations. Intratubular corticosteroid examination, though I have told, is limited scope, and the viscosupplementation can be given depends on the stage of the osteoarthritis, not useful in the late stage. Now they come to NSAIDs. The inflammation is the basically dynamic process by which the tissues react to injury. So this is the inflammatory cascade. If there is a tissue damage, there is activation of membrane phospholipid. There are two pathways: the LOX pathways, the glutocin pathways, and the COX pathways. These are the mediators of the inflammatory response: the complement system, the histamine, the serotonin. The bradykinin is the also major contributor to symptoms of inflammation, leukotrienes, and the prostaglandins. So these are some mediators of the acute inflammation. Bradykinin is a potent endogenous analgesic substance, and many studies have demonstrated the association with pain in humans. The classification of the COX inhibitors, the cyclogen acts on two pathways, the 1 and 2. The COX-1 are constantly expressed in a wide variety of cells over the body, but more abundant in gastric mucosa, and COX-2 is individual enzyme with immediate and early product in inflammatory immune cells. So there are COX-1 selective inhibitors. There's ketoprofen, mefenamic acid, pyridoxine. There's COX-2 selective inhibitors are diclofenac, itrocoxib, and celecoxib. Preferential COX-2 is meloxicam, itrodorac, mefezolac, and indomethacin, and both COX-1 and COX-2. These are the inhibitors are ibuprofen, lornoxicam, naproxen, etc. But the drawbacks of ibuprofen is impairment of renal function and oliguric renal failure, hepatotoxic, risk of GI bleeding, and there is also some cardiovascular toxicity. Pyridoxicam has high incidence of side effects. This is diclofenac and acetaminophen have incidence of intestinal ulceration, drug interaction, cardiovascular toxicity, risk of GI bleeding. Lornoxicam is avoided in pregnancy and lactation. Itrocoxib in pregnancy is strictly contained, and there are some cardiovascular issues. And all these drugs, they don't have effect on bradykinin. So we have to maintain a balance between NSAIDs. The issues are efficacy, tolerance, regimen, compliance, and cost, and must be safe, selective, fast-acting, powerful, and multi-target action. So jaltoprophen is a newer NSAID, which is a potent non-steroidal anti-inflammatory drug with preferential COX inhibitor and novel mechanism of action involving the potential effect on bradykinin. The bradykinin is an endogenous peptide formed in plasma and peripheral tissues. Bradykinin B1 and B2 are involved in causing chronic pain. Bradykinin activates a number of different signal transduction systems, including 12 blocks PLC beta, COX-1 and 2, and others by acting on bradykinin B2 receptor. The prostaglandin is released by downstream stimulated nociceptors. Disease activates other mediators such as bradykinin. So the blood supply cause to tissues to swell. This results in pain and inflammation. The inhibition of bradykinin can offer anti-inflammatory action as well as an additional benefit. The mechanism of action of jaltoprophen is it is potent analgesic action on bradykinin-induced nociceptive response by blocking B2 receptor-mediated pathway in the primary sensory neurons, and it also causes inhibition of COX-1 and COX-2. So COX inhibitors in combination we commonly use are ibuprofen paracetamol, diclofenac paracetamol, lordoxicam paracetamol, pyridoxicam paracetamol, and acetaminophen paracetamol. Paracetamol is the safest analgesic and antibiotic for an effective control of pain. And coming to some newer drugs we use, that is the glucosabine. So what is glucosabine? Glucosabine is an amino derivative of glucose, is the precursor of glycosa aminoglycosan, which is the structural component of cartilage. It is available in different forms: hydrochloride, sulfate. How oral glucosabine works? Always there is a question in the mind. the hydrochloride and sulfate forms are salts which dissolutes in the stomach, creates a glucosamine-free base. The percentage are different from sulfate and hydrochloride, but the glucosamine-free base are absorbed in the bloodstream, and that can be uptaken by the joint tissues. But in 2016, the American College of Rheumatology official journal, they says that the combined treatment with chondroitin sulfate and glucosamine sulfate shows no superiority over placebo for reduction of joint pain and functional impairment with patients with knee osteoarthritis. And what about these newer drugs like these native collagen 2, that is undenatured collagen type 2, and what is the mechanism of action? This undenatured type 2 collagen is derived from the chicken sternum cartilage. Its dose is 40 mg per day. There is a very good well tolerance, and the clinical studies support that the safety and efficacy of the AUC2 in moderating joint discomfort in osteoarthritis. So the mechanism of action is something different. Is orally taken UC2, these antigens interact. These are taken by the Peyer's patches in the small intestine, interact with the Peyer's patches in the gut, which ultimately turns off the T-cell attack to the structural protein collagen type 2 in the cartilage. So the mechanism is entirely different. It does not go to the joint. It works uptaken by the Peyer's patches and acts through this immunomodulator mechanism. And there is some difference between UC type 2 and hydrolyzed collagen. Hydrolyzed collagen is non-specific, and is the oral absorption is yes, and mechanism of action is mainly anabolic but not immune mediated as like UC2. And there are some literatures which supports the efficacy of the UC2, but we must individualize the patient for medical management of the osteoarthritis knee. There must be a pain rating scale for the for monitoring the prognosis, and the patient should maintain a diary, and we should educate the patients, and we should the parenting therapy as a physician-patient partnership. Thank you for your patient hearing.
Yes, Kiranda, please stop sharing your screen. So any question from expert panel?
Yes, I have a question.
Yeah, please, sir.
I am not in the expert panel.
Yeah, please, sir. You are expert enough, sir, to ask to guide us and ask questions.
So
You are
Kiran,
always in the expert panel, Jiten. Go ahead.
so what you have mentioned, it's okay, and we probably all know on the basis of that this particular disease, that is osteoarthrosis, is a degenerative disease. This is the concept. And the inflammation, what is taking place is as an effect of the late effect of the degeneration. But in the biology, 3 years back, this concept has been totally changed. It is essentially considered as primarily it is an inflammatory disease. The cartilage cell at stress that will liberate lot of cytokinins and initiates the inflammation within the joint, and subsequently different enzymes liberates which causes the damage. This is the newer concept of the biology of this disease. Naturally, the treatment is also targeted towards the control of inflammation of this, apart from the other non-medical, the physiotherapy, lifestyle regulation, weight reduction, etc., all are common. But regarding the therapy of the NSAIDs, it is considered to be the etorecoxib is probably the one of the most important drug. But because of its cardiac side effects, it is limited for long-standing use. So what the research is going on, that is on how etorecoxib can be administered through the joint intra-articularly in the nanoform particle combined with some other chemicals, that is PLLA, PGLA, PEG and PGLA combination, and then it is converted into nanoparticles and it is injected inside the joint. That will cause inflammatory effect long-standing, and the side effects are alleviated. So this long-standing side effect is because of this drug is when released, this unique drug delivery system, the drug is first released in a Hassenfeners, then it is slowly liberated, and ultimately at the end of 3 weeks, again there is a busting of the drug delivery. So this is the recent treatment, and probably within few years, probably the medical treatment will be concentrated on the NSAIDs and in this unique drug delivery system, that is nanoparticle within the intra-articular, avoiding the side effects of the NSAIDs. These articles are published in 2019 and 2020 only. Do you agree with that?
Obviously. Thank you. Actually, any damage to tissue in the human body, that initiates the process of inflammation. So it's what you are telling is absolutely true. There is but initially when there is just the first phase, so it's only damage the cartilage. So there is a theoretically there is inflammatory reaction, but the expression is not there. But when it the damage is more severe, so inflammatory process will be there.
Very right, because in this stage 3 or 4 disease, then the surgery replacement is probably the answer. But prior to that, when there is mechanical problem like the varus deformity, then high tibial osteotomy may be the good option. So I am not talking on that. Regarding the basic biology of this disease and its future drug therapy, what is the reason I am talking on that? Those are all agreed.
Obviously, and this is
and there is another recent advances in the strontium ranulate therapy, which was previously we used for the osteoporosis, but several articles published on that issue, strontium ranulate, and is accepted as one of the modality of treatment.
Thank you for your input on recent advances of the medical management of the osteoarthritis.
Yes, exactly.
Can I add one comment here?
Yeah, please, Arnav.
So I think there has been many researches going on to detect a particular antibody against the cartilage. As we have anti-CCP antibody in rheumatoid, to be specific. So as osteoarthritis has also been detected as an immune mediated. So it's an immune response which is generated by these fragments of cartilage within the joints, and then it increases. So that is why the newer molecules like undenatured type 2 collagen, which is acting through this T-cell regulation pathway. So more and more research is actually going through this way, and they are trying to pinpoint and identify specific antibodies and the structure or components of cartilage, which is actually responsible for this continuous immunological which is going within the joint, and that is why.
Yes.
So in this manner, I think there will be newer molecules.
But if it is a immunomodulated disease, then how it can be an universal one?
Because that is related to the normal
100% people.
Sir, that is why, exactly. So that is why it is mostly involving the knee joints, because or the large joints, which is actually taking the much load. Because of these regular micro injuries or regular wear and tear within these joints, this cartilage flex is actually inciting the immunological response inside. So actually they are trying to pinpoint which is the exact area, which is the exact component of the cell that are actually giving this immunological insight within this.
Yes, Arnav, that is another way of thinking on it. And, yes, remember, sir, please. So we can't hear you. Increasers, I think you have to increase volume here. No, you have muted yourself. So we can't hear you. I think we have done the. I remember sir is having some problem with the audio, so I think we can go with our last lecture by Ram Prabhoo sir. Sir, are you ready with your?
No. Thing is that I think that same ZOTP lecture was there, which Dr. Kiran has covered it. So I don't.
All right. Oh, then it's done. So I think we can continue with the discussion and question and answer. So Kiranda, what is your say on role of viscosupplementation? So at what stage of arthritis you prescribe it or you advise?
And another issue I'm not including in this lecture. Viscosupplementation cannot be. It's not effective in advanced stage of osteoarthritis, but is very effective in stage 2. But stage 3 is controversial. Stage 4 is not at all effective.
See, there are actually proponents of this giving viscose supplement. There are lots of proponents who do not really use them. I myself don't use it so much unless the patient really says that he has been asked to give. In fact, I was one of the first few last 20 years ago that we did a trial on 25 patients using Sinvis, and then I had given my frank opinion. And of course, these patients were grade 1 and 2 osteoarthritis, and the effectiveness over a next 1 year period that was checked. If we say that it's going to give you a relief for 1 year, I think we are not true to the patient. It sporadically, of course, gives good results in many patients, but that doesn't mean that it is uniformly true in most of the patients, And because the cost factor, which was, of course, that time also it was quite costly, the cost factor, we cannot really promise good results in everybody. In fact, some patients who were given hydrocortisone or cortisone injections also were equally happy with intra-articular injections more than the viscose supplement. So we really don't know how much is the efficiency, but there are some people who have been regularly using and they are happy with it. We really don't know the relief of pain for how many days it's going to last. But then, of course, certainly we are going to resort to physiotherapy exercises, strengthening muscle exercises, which are as good as giving some kind of painkillers or doing viscose supplements. But of course, if somebody is for operation and probably will go in for operation, elective surgery or otherwise in a year or two, and if we want to give these viscose supplements and just help them to tide over the crisis and to buy some time, okay, it could be given.
Sir, viscose supplementation usually don't have any side effects. Only one side effect is that is the local inflammation that lasts for 2 days, not more than 48 hours. So there's the usual common complication. But for intraarticular steroid, there are limitations. We can't give intraarticular steroid in regular interval.
Kiran, the main problem of viscose supplementation is not side effect, but equal to side effect is the cost.
That's another question. But corticosteroid will definitely improve. But it's a I think long-term use or frequent use is not indicated.
I think audio problem. Yes, sir. Please, sir. Please.
I have some experience on viscose supplementation. That is high density hyaluronidase. It do work, and it works at least 6 months. But the problem is, after 6 months or to 1 year, it should be limited. It should be repeated. So the persistent effect can be obtained. But obviously, it is not recommended, or it is not good for the terminal diseases such as stage 3 and stage 4. When it is stage 2, in stage 1, people usually do not allow to administer it. But in stage 2, my all cases are either stage 2 or borderline stage 3. Then they are definitely benefited for a period of 6 months to 1 year. So this is my experience.
So how many injections would you like to give? How many at maximum?
Yes, because it is not the curative form of treatment. So the benefit persists for 6 months or to 1 year. So you repeat it after 1 year or 2 years. In the stage 2 stages, then it will not progress to the stage 3, or it will take a lot of time to progress to the stage 3 or stage 4 disease. So arthroplasty or something, whatever is indicated, that will be much delayed. And in some cases, maybe a little elderly, I have experience of few cases who do not have the need of the arthroplasty even today, after 7-8 years. But
So,
the
but
injection,
my question remains, how many maximum injections have you given in one patient?
Actually, I have the experience of only three in 3 years. Yes.
Yeah, Rajiv sir.
And after that, somehow she feels better.
I feel that whenever there is a mechanical axis problem, there is a varus, valgus, I think these injections really do not help.
No, certainly that should be corrected. There is no doubt about it. If it is mechanical, that should be addressed.
Yeah, Rajiv sir.
I think there's a lot of things we still don't understand about arthritis. You see these really crappy X-rays, and the patient is quite happy walking along, and we see this non-crappy X-ray, things are not that bad, and patient is hobbling with pain. I think this is the studies on inflammatory mediators and antibodies. That is, I think, a major.
You are lost.
We can't hear you. Rajita, we can't hear you. We can't hear you. So Golok sir, Golok Behari sir, I think your audio is now on. So what is your indication for steroid injection in arthritic knee?
Hello.
Yeah, Golok sir.
Yeah, do you hear me?
Yeah, we can hear you. So
yes,
regarding steroid injection in osteoarthritic knee for pain management, what is your say?
What I'm telling you, the end of the day is whether the patient is feeling better or not. Lots of treatment are there. I am practicing in a district town for the last 40 years. So I have seen that it's not the question of the medicine. It's a question of the patient. You have to choose the patient for your treatment. Which treatment is implied for that patient, that is the most important.
Just give me 10 minutes.
Just a few minutes before, Dr. Paul said he can differentiate stage 1, stage 2, and stage 3. But at my 74 years, I can differentiate. What is the method of differentiation he can assess? If he tells, I'll be very much glad. It will help me. I only depend what is the medicines that the cartilage remodeling medicine or cartilage regeneration medicine and some NSAIDs or pain relieving medicine that is available, and later on there is an operation that Dr. Prabhoo says, the correction of the axis, etc., valgus, varus. There are many differentiation. There are many operations. So I think one day it will come after this immunology study and etc., that the stem cell therapy will come. Probably I will not be here because I am 74, but it will come on. The young man, they will tell that by the stem cells it will be cured totally. But till I can think that it's a question of the patient which I am treating and in which stage on clinical basis. There is no differentiation in clinically, in your radiologically, or by scan, or by MRI in stage 1, 2. In stage 3, there may be some difference. When this glucosamine and chondroitin came in market, the chondroitin is not absorbable at all. It absorbs at least 5%, so it is a discarded product at this moment. But when the glucosamine, they came in a combination form, everybody told, it will be effective when it's only 20% degenerated. But how can I assess? But in my practice, I usually think of the age, think of the profession, think of the type of work, whether he is working in a squatting position, the physique, the type of work. Then I differentiate whether it is in which stage. And in my many prescriptions from the countryside, from the quack practitioners and others. They use very costly medicine than me. They use more costly medicines than me. But I think those are not needed. And those medicines are used by them not for a long time. And that is, suppose your any combination product like glucosamine or any chondroitic, so they use for 15 days, then they have stopped. Patients are not taking because there is no use, there is no improvement. So there cannot be improvement. So one thing I can tell you, please choose your patient which treatment should be given to them. Don't choose the medicine for them.
Thank you, sir. Thank you, sir.
It's my opinion. And Dr. Pal, can you tell me how can you differentiate stage 2 and 3?
Stage 2 and? So radiological.
You are using
it is radiological findings.
Yeah.
And
radiological findings.
But the most important is to take the X-ray in proper way.
I shall talk to you when we meet.
Yeah.
Okay.
Yeah.
Over.
So Rajiv, I think now you are audible.
He's covered. Dr. Maji has covered the point. Don't worry.
Yeah.
That's what I was trying to bring it. It's very the treatment has to be individualized.
That was my last slide. That every patient must be individualized.
Absolutely,
Yes.
agree with you.
So I think we have a wonderful webinar on pain management, and Chinmay, Partho is there. Partho?
I think we can have a
Partho is not there. Yeah. So Chinmay is
Rajib da. At the end, we can have a message from the company person.
Yeah, yeah. Anyone is there from?
I think Mr. Dibyendu Goswami, if you want to say something from JB.
Mr. Dibyendu?
Are you there?
Yes, sir. Yes, sir. Sir, good evening.
Please. Yes.
First of all, we on behalf of JB
We can't see you.
Chemicals.
Just adjust your screen.
Okay.
Yeah.
Sorry.
Yes.
Good evening once again, sir. First of all, we paid a sincere thanks to Honorable Speaker Dr. Prabhu and the Association of West Bengal Ortho Associations. We really have paid sincere thanks each one of you. Really, we learned a lot of things during COVID-19 situations, which we were not aware well. And thank you, Dr. Prabhu and all participants. And once again, thank you to West Bengal Ortho Associations. So that is from my side.
Thank you.
So
now, message from Chinmay.
Yeah. Partho has joined, I think. Partho?
Yes. Just I am moving somewhere, so I cannot switch on my video. But the thing is that today's is a very useful topic for today's webinar. And I must thank Dr. Ram Prabhoo sir for sharing his experience. And it is a very useful topic, that is the COVID situation, how to deal with the COVID situation. I think this is the most successful webinar. And in this Zoom only, we have 73 participants in the Zoom only. So it is a very attractive webinar. And I must thank our past president, Golok Maji sir, Protyush Chatterjee sir, and past secretary, K K Mukhopadhyay sir, and Rajib Chatterjee sir. And also thank our webinar committee for making this type of topic. And tomorrow we have also another topic that I will communicate with you all later on. And thank you for making this conference success. Thank you all. Good night.
Okay, let me have a word. I really thank the West Bengal Orthopaedic Association and all the office bearers who have allowed me and given me this honor and prestige to interact with you all. And I will always, anytime called for anything, will be very happy to share my experiences and be with you. So thank you all, the seniors and all the faculty to be with me.
Thank you, sir. Thank you, sir. Stay safe, stay well, and thank you, everybody.
And I have one thing to mention, that it is the topic for the osteoarthritis, and it is only J.N. Pal sir who has made this topic complete. That the use of this that is the articular injection, interarticular injection. So thank you, sir, J.N. Pal sir, and thank you all for making this conference.
Golok sir has one question, Partho.
One question.
Happy Doctor's Day to everybody.
Yes, sir. Sir, one question is there from our past president, Golok sir. Yes, sir, please, sir.
In the next topics, in the previous topics, I'd like to tell something. But for sanitizing, your use, that is your hypochlorite. But if I use 70% ethanol for that purpose, is it more useful?
For surface sanitization, sir, Ram Prabhoo, sir.
No, it is not proved to be more effective than sodium hypochlorite.
We use our
we must see the cost effectiveness. We must also see the safety.
We use, let us tell me, for hand washing we use not methanol. That is very dangerous for the human being. Skin, etc., etc. It's a poison. But we are using ethanol. That is a constituent in almost all the hand sanitizers. And that is in 80% concentration. When you are using the hypochlorite, that is injurious to your skin, injurious to your lungs, and it very with a bad purpose.
No, sodium hypochlorite is used for spraying and floors and walls, not for hand washing.
No, not for hand washing. If I use that sanitizer, which are being used for our hand sanitization, for the room sanitization in a small chamber, is it useful or is it ethical? It is a costly bit, I think so.
You are talking about ethanol or sodium hypochlorite?
Ethanol.
The hand rub, whether we can use on
I don't have an experience of using ethanol, nor has any guidelines been given about this. So maybe I'll do some study and give you an answer later.
The only thing, Golok sir, is sodium hypochlorite. You can mix it with 15-liter saline. I think it's very cheap, so you can use as a spray. And so I think
it's a spray.
So that is the only thing. So it will kill the aerosols also, which cannot be done with this non-based solutions.
No, that is the standard protocol.
Yeah.
Everything we do with the papers and etc. etc. That is, I am asking you whether it can be used or not, because you are using it as a hand sanitizer for just taking photo. If we use for the room sanitizer, can it be used? It is safer than your hypochlorite. It is my point.
Yeah.
So maybe I will read about it and I'll be able to answer that.
Yes.
Because at the moment, I really do not have any experience, nor has any guidelines said about ethanol.
It's my thinking regarding this. If I can avoid the hypochlorite, it's costly. It's a costly, no doubt. Hypochlorite is very cheap, but it's costly. So it's my advice.
So for mass sanitization, I think they are using hypochlorite here.
Okay, thank you.
All right, sir. Thank you, sir. Stay safe, stay well. Happy Doctor's Day.
Thank you.
Good night. Take care.
Good night, sir. Good night.
Yes, sir.
Thanks a lot.
Thank you, sir.
Yeah.